If you have been clearing your throat several times a day, every day, for months or years, and you have been told it is just allergies or acid or something that comes with getting older, this video is going to give you a more complete picture than most of those conversations did. Because the sensation of mucus in the throat, particularly when it is persistent, is one of the most commonly mismanaged symptoms in adults over 60. Not because the physicians discussing it are wrong, because the causes are multiple, they frequently overlap, and the correct one is often not the first one that gets treated. Before anything else, an important note. This channel covers general education, not medical advice, and I am not your doctor. Nothing here is a diagnosis or a prescription. If you have had persistent throat mucus for more than a few weeks, especially if it is accompanied by difficulty swallowing, unexplained weight loss, blood in the mucus, or a hoarse voice that does not improve, please see your physician. Those symptoms, in combination, warrant an evaluation that a video cannot provide. With that said, let me walk you through what is actually happening in the majority of cases, because the truth is more specific and more actionable than most people have been told. Tell me your age in the comments right now and whether this is something you deal with daily. I read them, and they shape what I cover next. Stay through cause number 3. It is the one almost no one names correctly on the first try, and it is behind more cases of persistent throat mucus in older adults than acid reflux and allergies combined. Here is a thing almost no medical discussion of this symptom explains first, but should. The sensation of mucus in the throat is not the same thing as excess mucus production. That distinction is the key to everything that follows, and without it, treatments get aimed at the wrong target. The throat, the back of the nasal cavity, and the upper airway are all lined with a continuous mucous membrane that produces mucus constantly, not as a pathological response to something wrong, but as a normal, essential protective function. In a healthy adult, the body produces roughly 1 to 2 liters of mucus per day across all its mucous surfaces. Most of this is swallowed without the person ever being aware of it. The process is so automatic, so continuous, and so well integrated into the background of normal physiology that healthy mucus production is genuinely invisible. You do not feel it. It is happening right now, and you cannot tell. This is the baseline from which everything else in this conversation departs. The sensation of mucus in the throat, that awareness of something there, the urge to clear it, the feeling of thickness or dripping at the back of the nasal passage, arises not always because more mucus is being made, but often because the mucus that is being made has changed its properties, or the mechanism that clears it has slowed, or the sensitivity of the tissues detecting it has increased. 3 different causes, 3 different treatments, 1 shared symptom. Understanding which of the 3 is driving the sensation in any individual is the entire clinical challenge, and it is why the first treatment tried is often the wrong one. Think of it this way. The throat is not a drain that is simply blocked. It is a system with a sensor, a clearance mechanism, and a fluid, and any of the 3 can be the problem, independently or in combination. The sensor is the sensory nerve network of the larynx and pharynx, calibrated to detect the presence of material on the mucosal surface. The clearance mechanism is the combination of the swallowing reflex and the mucociliary transport system, the rhythmic beating of microscopic ciliated cells that sweep mucus upward and out of the airway. The fluid is the mucus itself, whose viscosity determines whether it moves easily or accumulates. When people come to a physician with persistent throat mucus, the physician is trying to determine which of these 3 components has changed, and the challenge is that all 3 can change simultaneously, in the same person, for different reasons. A thorough evaluation takes more time than many appointments allow, which is why a patient who walks in with specific, organized observations about their own pattern is more likely to receive a targeted diagnosis than one who simply reports the symptom. Cause 1. Postnasal drip, the real version, not the catch-all version. Postnasal drip is the most commonly cited explanation for persistent throat mucus, and it is cited so often that it has become a kind of default answer that gets applied whether or not it is actually the correct diagnosis. True postnasal drip means that mucus produced in the nasal passages or sinuses is draining backward and downward into the nasopharynx, the space behind the nose and above the throat, and accumulating there faster than it can be swallowed or cleared. This happens for specific reasons. Nasal congestion that reverses the normal airflow-assisted anterior drainage, chronic sinusitis that increases mucus volume, allergic rhinitis that both increases production and changes the consistency of nasal mucus to make it thicker and harder to clear, or vasomotor rhinitis, a non-allergic irritability of the nasal blood vessels that produces excess mucus in response to temperature changes, spicy food, dry air, or strong odors. Each of these has a distinct cause and a distinct treatment profile. A saline nasal rinse helps by physically removing mucus and reducing the inflammatory environment that perpetuates it. Nasal steroid sprays reduce the underlying mucosal inflammation that drives chronic postnasal drip in allergic and non-allergic cases alike. Antihistamines address the allergic component, but here a word of specific caution for adults over 60. First-generation antihistamines like diphenhydramine carry significant anticholinergic risks in this age group, including confusion, urinary retention, and effects on cardiac conduction. Second-generation antihistamines like loratadine or cetirizine are generally better tolerated in older adults and produce less sedation. Always discuss which option is appropriate with your physician or pharmacist, particularly if you take other medications. True postnasal drip is very real, very common, and very treatable when the right subtype is identified and the right intervention is matched to it. There is one more variable worth naming here. The consistency of mucus matters as much as its quantity. Allergic rhinitis tends to produce thin, watery mucus that runs freely. Chronic sinusitis and certain infections produce thick, tenacious mucus that moves slowly and accumulates. Vasomotor rhinitis often produces a clear, watery drip triggered by specific environmental stimuli. Knowing which consistency you are dealing with helps guide treatment. Thick mucus benefits from hydration, steam, and sometimes a mucolytic agent like guaifenesin, always under a physician's recommendation. Thin, watery mucus is more responsive to antihistamines and nasal steroids. Paying attention to consistency is a piece of self-observation that costs nothing and can significantly sharpen the clinical conversation at your next visit. Cause 2. Laryngopharyngeal reflux, the acid that burns without the heartburn. This is where the clinical picture gets genuinely interesting and where the most missed diagnoses live. Most people associate acid reflux with heartburn, the burning sensation in the chest that follows a meal and announces that stomach acid has traveled up into the esophagus. That presentation is gastroesophageal reflux disease, GERD, and most people recognize it. But there is a second and distinct form of acid reflux called laryngopharyngeal reflux, or LPR, in which stomach acid, or pepsin, the digestive enzyme, travels all the way up past the upper esophageal sphincter into the larynx and pharynx. The characteristic feature of LPR is that it often presents without heartburn at all. The larynx and pharynx are far more sensitive to acid damage than the esophagus, which has a more robust protective lining. Even small amounts of acid that reach the larynx can produce significant mucosal irritation, triggering a thickening of protective mucus at the site of irritation, a chronic urge to clear the throat, a sense of something being stuck, and often a mild chronic hoarseness. These are the symptoms. The chest is not involved. And because the chest is not involved, many adults with LPR spend years treating what they think is allergies or postnasal drip with limited success because the underlying cause is acid exposure in the upper airway. LPR is often worse at night because lying flat removes gravity's assistance in keeping stomach contents down, and because swallowing frequency drops during sleep, which normally helps clear acid from the esophagus. The sensation of mucus in the throat that is most prominent in the morning, that thick, uncomfortable accumulation present upon waking that takes 30 minutes to clear, is a classic LPR presentation. A 2015 review published in the journal Current Opinion in Otolaryngology confirmed LPR as one of the most common and most underdiagnosed causes of chronic throat symptoms in adults. Treatment involves dietary modification, timing of meals, positional strategies during sleep, and in some cases, acid-suppressing medication under physician guidance. Never self-prescribe acid suppression long-term without a physician's oversight. If this matches your pattern, bring it to your doctor specifically by name: laryngopharyngeal reflux. The distinction from GERD is not widely known, and naming it may speed the conversation considerably. Type the number 2 in the comments if this sounds like your pattern. It helps this reach more people dealing with it. Cause 3. This is the one I told you to wait for. Laryngeal sensory neuropathy, or more broadly, sensory nerve hypersensitivity in the throat, is the cause that is behind more cases of persistent throat mucus in older adults than most people are ever told, and it is the cause that most commonly leads people through years of treating the wrong thing. Let me explain what it actually is. The throat and larynx are richly innervated by sensory nerve fibers, primarily branches of the superior laryngeal nerve, a branch of the vagus nerve whose job is to detect the presence of foreign material, irritants, or changes in the mucosal surface, and signal to the brain that something needs to be cleared or swallowed. In a healthy, normally calibrated sensory system, these nerve endings respond to real stimuli, actual mucus, actual irritants, actual changes, and produce an appropriate clearing response. In some older adults, particularly those who have had viral respiratory infections, nerve compression, or cumulative irritation from chronic cough or chronic throat clearing itself, the sensory threshold of these nerve endings drops. They become hypersensitive, responding to stimuli that would not normally register as significant. The sensation of something in the throat becomes persistent, not because something is actually there, but because the sensory system has been recalibrated to a hair trigger. This is laryngeal sensory neuropathy, and it has received increasing clinical attention over the past 15 years. A critical review published in the Journal of Voice in 2012 by Bastian and Veith described the condition as a sensory neuropathy of the recurrent and superior laryngeal nerves that produces a range of symptoms, including the persistent sensation of mucus or foreign body in the throat, chronic throat clearing, and globus, the feeling that something is perpetually stuck. The reason this matters so much for older adults specifically is that the nerve changes associated with sensory neuropathy in the throat are the same class of changes that produce other neuropathic symptoms in aging: reduced conduction velocity, increased baseline sensitivity, prolonged recovery after irritation. The chronic throat clearing itself is one of the most counterproductive responses possible to sensory neuropathy, because every throat clear is a fresh mechanical trauma to the mucosal surface of the larynx, which perpetuates the irritation that is sensitizing the nerve endings further, which produces more sensation, which produces more clearing. It becomes a self-sustaining loop. The treatment is not a medication. It is a voice therapy technique called the habit reversal technique, replacing the throat clear with a hard swallow followed by a sip of water, which clears the sensation without the mechanical trauma. Practiced consistently over several weeks, it interrupts the loop, allows the mucosal irritation to subside, and gradually recalibrates the sensory threshold. A speech-language pathologist who specializes in voice disorders is the appropriate referral for sensory neuropathy presentations, and that referral is worth asking your doctor about specifically. It is worth pausing here to say something about why this diagnosis is so commonly missed in older adults, because the reason is not negligence. It is time and precedent. Sensory neuropathy of the larynx does not show up on the standard examination. The throat looks normal. The sinuses look normal. Allergy tests are negative or mildly positive. Acid suppression produces partial improvement, possibly because acid was contributing as a secondary irritant, but the fundamental sensory sensitivity remains. The physician, working within a constrained appointment, moves to the next most likely diagnosis. The patient, having had partial improvement, accepts that this is as good as it gets. The cycle continues. Naming the condition, asking specifically whether laryngeal sensory neuropathy might be contributing, and whether a voice therapy referral would be appropriate, is the step that breaks that cycle. You are not questioning the physician's competence by raising it. You are adding information that was not previously in the room. Cause 4. Dehydration and mucus viscosity. The simplest cause and the one most often overlooked in the medication conversation. Mucus is roughly 95% water. The remaining 5% is a protein scaffolding called mucin, which gives mucus its characteristic gel-like consistency. The ratio between water and mucin determines whether mucus is thin and easily transported by the ciliated cells of the airway, the microscopic hair-like structures that beat rhythmically to carry mucus up and out of the lungs and throat, or thick and slow-moving, accumulating in the throat and upper airway because the cilia cannot move it efficiently. When the body is even mildly dehydrated, which is a chronic state for many older adults because the thirst mechanism becomes less sensitive with age, meaning people in their 60s and 70s often do not feel thirsty even when their hydration status is suboptimal, the water content of mucus drops, increasing viscosity. Thick, viscous mucus is the mucus you feel. Thin, well-hydrated mucus is the mucus you do not. The clinical implication is that a meaningful proportion of older adults dealing with what they perceive as excess throat mucus are actually dealing with normal quantities of mucus that has become more concentrated and therefore more sensorially prominent. The intervention is not a medication, it is hydration. Roughly 6 to 8 cups of fluid per day for most older adults, with adjustment for body size, climate, activity level, and any medical conditions affecting fluid balance. Warm fluids are particularly effective because heat reduces the viscosity of mucus acutely, which is why tea and warm broths have been used empirically for this purpose for centuries. The dry air environment of heated or air-conditioned indoor spaces also thickens mucus by drawing water from the mucosal surfaces of the upper airway. A room humidifier, particularly in the bedroom during sleeping hours, restores some of that moisture to the airway environment and is one of the lowest risk, most consistently helpful non-pharmacological interventions available. Consider a woman in her late 60s. Call her someone who had been taking a daily antihistamine for 2 years for what her doctor had diagnosed as allergic postnasal drip, with limited benefit and increasing daytime fatigue. She mentioned the fatigue to a nurse practitioner covering for her physician, who noticed she was not drinking enough fluid and had a chronically dry indoor environment. 3 weeks of consistent hydration and a bedside humidifier produced more improvement in her throat symptoms than 2 years of antihistamines had. Her original postnasal drip diagnosis may have been partially correct, but dehydration had been amplifying the sensation the entire time. The two causes had been running simultaneously, and only one was being addressed. Cause 5. Medications as a direct cause of throat mucus changes, and the most common culprits are ones that are not intuitively connected to the throat. ACE inhibitors, the blood pressure medications that include lisinopril, enalapril, and ramipril, are one of the most commonly prescribed drug classes in adults over 60. They are also, in a significant subset of users, the direct pharmacological cause of a persistent, dry, tickling throat sensation and accumulation of mucus. The mechanism involves bradykinin, a compound that ACE inhibitors allow to accumulate in the lungs and upper airway, and elevated bradykinin irritates the mucosal surface of the larynx and pharynx, producing a chronic, low-level inflammatory response that generates protective mucus at the site. It is the same mechanism responsible for the ACE inhibitor cough that affects 5 to 20% of users, with higher rates in women and people of East Asian descent. But the presentation is not always a frank cough. In some patients, it presents as a persistent sensation of mucus or the need to clear the throat, without a frank cough at all. If you have been dealing with persistent throat mucus since starting or increasing the dose of a blood pressure medication, this connection is worth raising with your physician explicitly. The fix is typically straightforward, switching to an ARB, a related class of blood pressure medications, including losartan and valsartan, which works through a similar mechanism but does not affect bradykinin. That switch resolves the throat symptom in the overwhelming majority of cases. Beyond ACE inhibitors, diuretics, also common in older adults for blood pressure and heart failure management, cause systemic dehydration that contributes to thicker, more viscous mucus through the mechanism described in cause 4. The interaction between a diuretic and inadequate fluid intake in an older adult is one of the most common and least recognized amplifiers of throat mucus symptoms in this age group. Never stop or change a blood pressure medication on your own. That is a conversation to have with your physician with this information in hand. One more medication category worth noting, because it is less commonly discussed in this context: inhaled corticosteroids, used for asthma and COPD management, can produce a condition called oropharyngeal candidiasis, a fungal overgrowth in the mouth and throat, or simply a chronic mucosal irritation from the particle deposition of the inhaler medication on the posterior pharyngeal wall. Both of these produce a sensation of mucus or thickness in the throat that is unrelated to mucus production itself. If you use an inhaler and have persistent throat symptoms, rinsing the mouth and gargling with water immediately after each use is the standard recommendation to reduce deposition, and it is a step many users are not taught when the inhaler is first prescribed. Cause 6. Structural changes in the upper airway that come specifically with aging and that are rarely discussed in a primary care appointment because they take longer to explain than a 15-minute visit allows. As adults move through their 60s and 70s, several structural and physiological changes occur in the larynx, pharynx, and esophagus that collectively make the sensation of mucus more likely and more persistent, independent of any identifiable pathological cause. The vocal folds, the two bands of tissue that vibrate to produce voice, lose some of their bulk and pliability with age. This atrophy, called presbylaryngus, changes the aerodynamic environment of the larynx in ways that alter the airflow patterns across the mucosal surface, which in turn changes the way mucus is distributed and how prominently it is perceived. The esophageal motility, the speed and coordination of the swallowing reflex, also slows with age. A slower swallowing reflex means that mucus accumulates in the pharynx for longer between swallows, which increases the likelihood of the pooling sensation that many people experience as excessive mucus even when production is normal. Additionally, the mucociliary clearance system, those ciliated cells that sweep mucus up and out of the airway, loses efficiency with age, with cilia beating more slowly and less synchronously than in younger adults. This reduced clearance efficiency means that even normally produced, normally viscous mucus stays in contact with the throat surfaces longer before being cleared, which increases the sensory exposure to it. Understanding these structural contributions does not provide a single fix, but it does provide context that changes how someone relates to the symptom, and that shift in frame matters practically, not just psychologically. When a symptom has a structural, age-related explanation, the response it warrants is management and adaptation, not alarm and escalation. It is not evidence that something is acutely wrong. It is evidence that the system has changed and that the strategies most likely to help are those that support clearance, good hydration, steam inhalation, the habit reversal technique for avoiding chronic throat clearing, and, where relevant, working with a speech-language pathologist on swallowing exercises that can improve the speed and completeness of the swallowing reflex even in older adults. Here is what the complete picture looks like. Persistent throat mucus in older adults is almost always the result of one or more of these 6 causes operating simultaneously, and treatment that addresses only one while ignoring the others will produce partial improvement at best. The majority of people in this age group dealing with chronic throat mucus have at least 2 causes active at once. Often some combination of mild sensory hypersensitivity from chronic throat clearing, mild LPR that is worse at night, and dehydration-related viscosity increase that is amplifying how prominently both of those are felt. That three-way combination explains why antihistamines alone, aimed at postnasal drip, so frequently provide incomplete relief. They are treating one piece of a multi-part picture. A practical approach for this week. Take a piece of paper and write down when the sensation is worst, morning specifically, after meals, during allergy season, since starting a medication, or all day, every day without a pattern. That pattern is the most useful clinical information you can bring to your physician. Morning worst points toward LPR. Season-linked points toward true allergic postnasal drip. Medication onset points toward ACE inhibitor, bradykinin, or diuretic-related dehydration. All day, every day, without a clear trigger, points towards sensory neuropathy as the primary driver, particularly if you have been a habitual throat clearer for years. Write it down, bring it in, ask your physician to consider each of these causes specifically before landing on one diagnosis, because the correct management depends entirely on identifying the correct cause. And be prepared for the possibility that the answer is more than one cause, addressed in sequence. The patient who brings this level of organized observation to a clinical visit is not a difficult patient. They are the patient who gets the most useful appointment. They are saving both themselves and their physician time because they have already done the first step of differential diagnosis at home, sorting the symptom by pattern. That step is genuinely valuable, and it is entirely within your reach. Tell me in the comments which of these 6 patterns matches your experience. I read every response, and your answers often shape the next video in a way that serves the whole community. If someone in your life has been dealing with this symptom without a satisfying answer, share this with them. Next, I want to walk you through the specific relationship between acid reflux and vocal cord changes in adults over 60, and why a hoarse voice in the morning is almost never just a coincidence. Watch that one next.